some recent in sarcoma. So if there's any technical glitches at any point during the presentation, please speak up. I have been known to like not realize it was happening and kind of talk when no one could hear me. So, and then you can see my cursor, right? Moving around. Yes? No?
No.
Okay. I will not depend on a cursor then.
Oh,
All
I
right.
just saw it.
Oh, you did? Okay. All right, so the title of the talk is Immuno-Oncology of Soft Tissue Sarcoma. I am a sarcoma surgeon here at MD Anderson. About 2 years ago, I focused on sarcoma from melanoma sarcoma practice, and then I also opened a translational wet lab. And so now my clinical practice is only treating patients with soft tissue sarcoma and doing sarcoma research. I have no relevant disclosures pertinent to this talk. This is a framework for today's talk, just in general to kind of get everyone on the same page. I don't know, the breadth of practice in the audience, but I wanted to share one framework for approaching how to take care of patients with soft tissue sarcoma. This is kind of how I think about new patients when I meet them. This is how I kind of go through the stepwise plan development of how to develop a treatment plan for patients when we have trainees in our clinic. I'll talk a little bit about how we apply systemic therapy for these patients, and then what the rationale is for increasingly people are combining immunotherapy in their management of patients with some of these soft tissue sarcomas. So as this group may know, there's a lot of challenges in the management of these tumors. So there's many different types of histologies and subtypes of soft tissue sarcoma. Every time the WHO puts out a new iteration of their classification system, there's greater number of these sarcomas as we learn more about them. Many of them, however, we really don't understand very well. We don't know what the drivers of these tumors are. And especially in a decentralized healthcare system like we have in the US, because these tumors are so heterogeneous and rare, they're often under-recognized at presentations, and many patients will have some sort of treatment rendered, often surgery, before the diagnosis is made that they have a cancer. There have been some incremental improvements in sarcoma-specific survival over the past, 5 to 6 decades in the US. And again, I think one of the limitations in our country is that over 95% of patients with sarcoma here are treated at a community setting, oftentimes not recognized to have a cancer before something is performed, like a excisional biopsy or incisional biopsy. So as surgeons, surgery is the cornerstone of resectable STS management. So we are not without a job anytime soon, at least for this subgroup of patients. So these are all patients that I've taken care of in my career so far. Very diverse. So, we have things like extremity leiomyosarcomas, extremity high-grade UPS, perineal tumors. So often these tumors are in very difficult locations, both from a functional standpoint and a reconstructive standpoint. Here's a case of a chest wall myxofibrosarcoma. And I think one of the challenges with this subtype is that people don't recognize how extensive these tumors can be. They're very infiltrative. The area involved can be quite large. And so it can be quite difficult to achieve negative margins in this particular subtype of tumor. Here's an adult rhabdomyosarcoma, so extremely aggressive tumor, not very chemoresponsive, very dismal outcomes. And you can appreciate this gentleman actually had a huge resection done somewhere else. Before it was recognized, he actually had lymph node mets. And this is an in-transit met. And so he, had already metastatic disease before he underwent this quite morbid surgery, and then came to our center. Technically, these surgeries can be very difficult. So this is a liposarcoma up top over here with both high-grade and low-grade components. There's really very little, volume in the abdomen that is normal. And she was malnourished and having trouble with eating. She had no room to eat. So, we did operate on this patient because she couldn't tolerate chemotherapy. She was only going to get progressively more malnourished with time. And then we also run into the challenge where sometimes individuals might recognize that there's a sarcoma, but may not recognize the full extent. So oftentimes this might be an example of a retroperitoneal sarcoma that extends into the inguinal canal and into the scrotum. And the extent of that disease may be underappreciated. Here's a leiomyosarcoma originating from the IVC, and again, technically quite challenging. Resection would require a nephrectomy. There's also abutment of the duodenum. We have to think about the vascular involvement, protecting the contralateral kidney, and then in this case, thinking about what kind of achievable surgical resection margins is possible in a surgery for this patient. So when you look at the NCCN guidelines, these are guidelines put out by different disease site-specific experts in our country. For sarcoma, there's really room for a lot of variability in how people manage these tumors. So if you have a resectable tumor, this is the case of a retroperitoneal sarcoma, you could do surgery alone. The guidelines also say you could give pre-op radiation. The guidelines also say you could do systemic therapy. The guidelines also say you could consider adjuvant. So how do you decide how you're going to manage these patients? These are the guidelines for the different stages of extremity soft tissue sarcoma. And at least for me, when I was a resident and fellow, I found this not particularly helpful as I was studying for my boards and thinking about how I would manage patients that come to my clinic as a junior faculty. So I think the first step is, when you meet a patient, think about what kind of histology they have and what the disease site location that their tumor is located in. These are very important for how the patients do. So if you focus on the black line, that these are patients with leiomyosarcoma, and this is for retroperitoneal sarcomas. This is from Dr. Gronke and the Tarpswig group. For leiomyosarcoma specifically, when I meet a patient, I know I'm going to be worried more about their distant metastatic disease in the future than their local recurrence. So they have quite low local recurrence risk, but quite high distant recurrence risk, right? If I take the case of a low-grade liposarcoma in blue, quite high local recurrence risk, but negligible distant recurrence risk. And then the D-diff lipos have both a high local recurrence risk and a fairly significant distant recurrence risk. So when I meet a patient, I think about, number one, what is their risk of these different recurrent types? So local recurrence risk, nodal recurrence risk, which is really applicable to just a very small subgroup of rare sarcomas, and then distant metastatic risk. And then I think about what kind of drug treatments and local regional therapies are even available, and is this a sarcoma type that even responds to these? So this is another case of a gentleman. He underwent an attempted resection at another facility in the country. He had a high-grade dedifferentiated liposarcoma. On imaging, he actually also had some disease in the lower chest abdominal wall, I think from biopsy needle track seeding. That's a pretty uncommon occurrence, but I suspect, maybe the biopsy technique was done a little bit differently than usual. So when I look at this patient, I think, okay, he's got a high-grade sarcoma. There's significant distant metastatic risk. We also do have some chemotherapies available for this particular sarcoma type, but I don't expect there to be significant radiographic shrinkage. For this particular sarcoma, I often think of it as like a test of the biology, like he's already recently had surgery a couple months ago. I'm not going to jump in and try to reoperate again this quickly. He also has some multiple other sites of disease. So in this patient, I'm favoring a trial of preoperative chemotherapy. I'm also favoring local recurrence because this is an area where it has been, in the words of one of our radiation doctors, mucked around, right? So I don't know how much contamination there is from the past surgery. There's also these tails that extend beyond the main bulk of the tumor. And then for the trainees, there's this tool that's free, that's an app that, I find useful. If you input some of these clinical variables, it will kind of give you the results of a nomogram risk score. So it will give you an estimate of what a particular patient's 5-year or 10-year or 7-year overall survival, distant metastatic risk is. And so this can be helpful when you're weighing the treatment options. All right, so then I think, okay, is there anything systemically effective, right? So if in the case of the rhabdomyosarcoma patient, the chemotherapies really don't work, and that was a very aggressive tumor. So one of the discussion points was, you know, how morbid of a surgery would it be? How likely are we going to be able to resect all his disease versus, this chemotherapies really don't work. And that was quite a challenging case. Um, the other thing I think about kind of all at the same time is what are the surgical options? How morbid is the surgery going to be? I know that without surgery, the patient's not going to have any chance of cure, right? So if it's a resectable case, there is going to be some component of surgery involved. I think about what kind of margins am I going to achieve? Is there one particular area of the tumor that I'm more worried about? Do I need to consider radiation for that particular reason? And then I think about what kind of reconstruction might be needed. Am I going to be exposing bone? Am I going to be stripping periosteum? Am I going to be exposing vasculature? And what kind of reconstruction, like a flap, will I need? And then for the case of leiomyosarcomas, really, that's the only histology where I might expect potentially there might be some downsizing of tumor. So generally, I don't expect the tumors to shrink a lot, either with radiation or chemotherapy, or really even immunotherapy. But I am using it to try to decrease the local recurrence risk for, in the case of radiation, and then in the case of chemotherapy, to kind of decrease the metastatic risk. And then the other thing that I think about is there are some situations where if the patient has a local recurrence, they really don't have any surgical salvage options. And so in those scenarios, oftentimes we'll be super aggressive about upfront neoadjuvant therapies before surgery. So what's the role of systemic therapy? So these are what have been available for chemotherapies before surgery. At our institution, we do a lot of neoadjuvant therapy. Other institutions may do upfront surgery and then adjuvant chemo more often. But across disease sites, we tend to favor giving radiation and chemotherapy upfront. Most of the time, if the patient's healthy on the younger side, good cardiac and renal function, we'll give doxorubicin ifosfamide. For the patients that are maybe older, less able to tolerate that regimen, we'll consider other regimens like gemcitabine and taxotere. I added doxorubicin and trabectedin here. We're finding that this has been associated with anecdotally quite significant response rates for patients with leiomyosarcoma. So almost all of our new leiomyosarcoma patients, we've shifted to this regimen compared to AIM or Gemtax as in the past. But this is not uniformly adopted across institutions. And then our studies that support the use of chemotherapy for retroperitoneal sarcoma are extrapolated from the data in extremity and truncal disease. And even in this setting, the findings are inconsistent. So studies looking at neoadjuvant chemotherapy have resulted in inconsistent findings. Same thing with adjuvant chemotherapy. But in the neoadjuvant setting, the combination of chemoradiation for extremity tumors has been shown to improve disease-free survival and overall survival for high-grade tumors at the expense of short-term toxicity. This includes complications, wound complications from extremity sarcoma tumors, resections. So, we'll see anywhere from a 25 to 30% wound complication rate after pre-op radiation followed by surgery for extremity tumors. And then you should know that there is an ongoing clinical trial enrolling patients with high-risk retroperitoneal sarcomas called STRAUSS-2, and this is randomizing patients to either upfront surgery or preoperative chemotherapy followed by surgery. All right, so there's really, for many subtypes of soft tissue sarcoma, there's really limited efficacy of the chemotherapies that we have available. So the case of this common type of sarcoma called undifferentiated pleomorphic sarcoma, in the past it was called MFH. And then it's kind of, many of us think it lies on the spectrum as myxofibrosarcoma. So these are patients where when they have metastatic disease, when they undergo treatment, about 40% of them will subsequently develop metastatic disease. So the risk of metastatic disease is quite high. In that setting, about a third of the patients will respond to chemotherapy. It's not terrible, but not great, but the responses are usually not durable. So usually they're on the first line chemotherapy for less than 5 months before they progress, and they move on to the next line, and their median survival in the metastatic setting is only 11 months. So people have asked, can we use immunotherapy to fulfill this unmet need in UPS treatment and other types of high-risk sarcoma in the metastatic setting? So what's the rationale for immunotherapy? We think of immunotherapy as being effective in kind of more highly mutated tumors like melanoma or, for example, bladder cancer and skin cancers. But the first example of an immunotherapy working was actually described by a surgeon in New York. So this was a bone sarcoma case report where he had injected like a slurry of adjuvant material that he extracted from infection from bacteria. He had noted that a patient with sarcoma with an infection had, spontaneous regression of his tumor. And he had tested this in a small series of patients with some results. So this was really the first example of immunotherapy working for a tumor type. Dr. Hussein Taubi is a medical oncologist who was the PI of SARC-028. This was one of the first trials studying immune checkpoint blockade in patients with sarcoma. And he ran this when he was at Pittsburgh, but he's now in our melanoma medical oncology group here at Anderson. And I was fortunate to meet him early in my fellowship training and got to working with him. And that's how I became interested in immunotherapy for sarcoma. So in this study, he enrolled different types of bone and soft tissue sarcoma patients. All these patients had been on either 2 or 3 prior lines of chemotherapy before. And then they went on the study, which was single agent anti-PD-1 therapy. They got some signal that there were maybe 2 types of sarcoma that might respond better to immunotherapy. So the bone sarcomas did not respond, but the patients in the blue and the kind of so the patients in the green and the red lines are the dedifferentiated liposarcoma patients and the UPS patients. And in these subsets of patients in this trial, there were some RECIST radiographic responses that were noted. And there were also some durable responses among these patients where there were, a handful of patients that had disease stability or persistent decrease in tumor burden. So that was really the first time that immunotherapy, had showed that there might be some potential for a select subset of patients with sarcoma. So in the NCCN guidelines, and often this is what insurance and payers will cover for patients in the US. If it's not in these guidelines, Medicare and private insurers will often not pay for these treatments. So in the metastatic setting, immune checkpoint blockade is listed as a potential option for UPS, for DDIF lipo, myxofibrosarcoma, and angiosarcoma. And then there is, of course, in the US, an indication that's agnostic of histology, and that's for highly mutated tumors or MSI high tumors. Alveolar soft part sarcoma in subsequent studies have shown exquisite sensitivity to immunotherapy. And so these are regimens that are available for those patients. I think as surgeons, we often don't meet these patients. They often present with multifocal disease and metastases already. All right, so working with Hussein and colleagues in France, Florent Petitprez was a grad student at the time in Wolf Friedman's lab. We then looked at samples from SARC-028, and we looked at the immune microenvironment of these tumors by gene transcription analysis. We validated this immune gene expression signature, which was called sarcoma immune class, or SIC, and we found that tumors could be subtyped into 5 different SIC classes, A through E, with A being really an immune cold tumor, C being a vascular type of tumor, and then E being an immune hot tumor. And you have patients with UPS, so in the red bars, some of them are sarcoma immune class E and some of them are not. But we also found that any tumors that were sarcoma immune class E, those patients tended to have better progression-free survival in this trial and tended to also have better response rates to pembrolizumab. Further analysis of this cohort as well as other cohorts, when we looked at the microenvironment, we noticed that sarcoma immune class E tumors also happened to be the ones that had these structures within their tumors called tertiary lymphoid structures. These are highly organized features in tumors that are composed of B cells, T cells, and dendritic cells. And then across tumor types, this has since been shown to be associated with more favorable responses to immune checkpoint blockade and better survival after immune checkpoint blockade. At MD Anderson, we've showed this in lung cancer and melanoma, as well as sarcoma, and then others have done this across other disease types as well. So kind of the next iteration of trial, so Dr. Italiano and the French group, the French sarcoma group, had a study called PembrSarc where they were studying metronomic cyclophosphamide as a way to inhibit T regulatory cells and combine this with pembrolizumab, again, for patients with metastatic disease. They took this TLS and they used a couple of IHC markers to basically look for patients with TLS in their tumors. And they found that if they just took all patients that met their original eligibility criteria, the non-progression rate at 6 months in this trial was very low. They opened an expansion arm of the study where they only enrolled patients where, on the basis of these 2 immunohistochemistry markers, only the patients with TLS in their tumors at baseline were enrolled to this cohort. And in that cohort, the non-progression rate was a lot better, 40% compared to 5%. The objective response rate was also better, so 30%, again, not like out of the ballpark, not stellar, but it's comparable to chemotherapy, right? Objective response rate around 30%. So this is an option for some patients with metastatic disease. And then the median progression-free survival in this advanced disease setting was also better. So as many of you, will know, how these immune checkpoint blockade inhibitors work is they act on different molecules that basically put the brakes on different immune cells in our bodies. So I'm not really talking about ipilimumab, which is an anti-CTLA-4 antibody. We're really more focused in this talk about blocking the PD-1, PD-L1 pathway, but these are molecules that are expressed on effector T cells and cancer cells and antigen-presenting cells to kind of keep control on our immune system from going haywire. So why are tumors that are more mutated more likely to respond? So, for sarcoma, the reason why for a long time we thought these were immune cold tumors is that in order for our immune system to recognize a cancer cell by this mechanism, there has to be some antigen that's presented in the context of MHC. And so this is why heavily mutated tumors may present more neoantigen or may express more neoantigen. When you look at sarcoma, both with respect to tumor mutational burden and tumor neoantigen expression, sarcomas are pretty low in expression of both of these types of antigens. Certainly compared to melanoma, MSI high tumors, and some of the other carcinomas that we think of as being more responsive to immunotherapy. And so this has led us now to the current state, which is combining radiation with immune checkpoint blockade. And there's several reasons why radiation may augment our response to immune checkpoint blockade. First is that radiation therapy may actually cause upregulation, increased expression of any neoantigens that sarcoma cells might make. It may also enhance and provide some adjuvant therapy in terms of stimulating cytokine production that may augment the function of our anti-tumor immunity. And then it may stimulate the cancer cells themselves to increase MHC and express neoantigens themselves and make the cancer cells more susceptible to our immune system recognizing them and killing those cells. So this is kind of one preclinical study that was performed by David Kirsch's group when he was at Duke. So MCA is a tumor model that was developed at the NCI by Steve Rosenberg. It generates a fibrosarcoma model in syngeneic Black 6 mouse background. They created these tumors by orthotopic injection of the cell line, and then they treated these tumor-bearing mice to either control, to anti-PD-1 antibody alone, radiation alone, or the combination. And anti-PD-1 alone in the fibrosarcoma model really doesn't really do too much. Radiation alone does increase the survival a bit, but it's really the combination that had the best effect. So this was kind of the preclinical data leading to the SARC-032 study. And so the SARC-032 study was recently reported last year by Dr. Kirsch's group and the clinical trial collaborators. So in this study, they enrolled patients with UPS, DDLPS, so high-grade extremity tumors. They randomized these patients to either radiation followed by surgery, which is often what many centers will give. Many centers will not do preoperative chemotherapy in addition to the radiation, or to radiation therapy concurrently with immunotherapy followed by surgery. And then all these patients then after surgery went on to receive adjuvant immunotherapy for up to a year. And this adjuvant therapy up to a year is basically a treatment paradigm that was established in melanoma and then just taken and done in sarcoma. But there's not really any particular rationale for why a year and why adjuvant therapy is also needed. Their primary endpoint was 2-year disease-free survival, and then they had secondary endpoints of local recurrence-free survival, distant recurrence-free survival, and overall survival. So one thing that was a little bit strange about their final manuscript was that so they did see a 2-year disease-free survival improvement between their experimental group and their control group, difference of 67% versus 52. But in their manuscript, they show just a one-sided p-value, which is a little bit strange. I think even with the two-sided p-value, people would have still found this finding quite interesting, and it would have been practice changing also. They had pretty balanced groups between looking at intermediate grade tumors versus high grade tumors. And then between the experimental and control arms, the tumor sizes were also about the same. When you looked at the survival curves, the disease-free survival curves between patients with intermediate tumors, between the two arms, not really a huge difference, really no difference between those two. But when you look at the high-grade subset of patients with high-grade tumors, that's where the patients in the experimental arm really seem to separate from the control surgery radiation alone arm. So one question that comes to mind is, how does this regimen of preoperative immune checkpoint blockade with radiation compare to preoperative chemo radiation? And of course, we don't have a head-to-head comparison or trials like this. So the best I would say is for us at our center, we have pretty much converted most of our UPS patients to getting neoadjuvant immunotherapy with radiation, particularly if they have some contraindication or they're more frail and we're worried about giving them preoperative chemotherapy. But I think we'll need more time to see how the long-term outcomes of these patients are, compared to the historic outcomes of patients with chemo radiation before surgery. These authors also at CTOS last year, which is our international sarcoma meeting that happens early November every year, they also broke down their correlative analysis and looked at which patients had sarcoma immune class E tumors and compared their outcomes to the patients who had non-sarcoma immune class E tumors. And they saw that overall, among all the patients, both in the control arm and in the experimental arm, those with sarcoma immune class E tumors had better just overall disease-free survival. When they looked at only the patients with sarcoma immune class E, and this is again based on RNA expression of immune genes from the tumors, just among patients with sarcoma immune class E tumors, the experimental arm did better than the control arm. But if you look at the patients who did not have immune class E tumors, the addition of immunotherapy really didn't seem to offer much additional benefit. So how are we clinically translating these results? Who are the right patients for this regimen? So typically, we are now considering it for patients with high grade tumors of the extremity. Historically, we're giving patients with high grade or intermediate grade tumors that are greater than 5 centimeter preoperative chemotherapy. So we're kind of keeping to that same paradigm in this combination immunotherapy radiation setting. But there may be patients that historically we were not giving chemotherapy to because we were worried about their age, worried about their cardiac and renal function, that we would be willing to give pembrolizumab with radiation. Another concern is there an upper size limit? So sometimes with immunotherapy, you actually see an increase in size initially with kind of edema and infiltration of immune cells into the tumor. You can get a phenomenon observed called pseudoprogression on their imaging. And people worry that, if there's a large tumor or a tumor in a particular tricky anatomic location, even with pseudoprogression, you may lose a window to operate. The trial, the SARC-032 trial really enrolled a lot more UPS patients than liposarcoma patients. So we are really applying it only to myxofibrosarcoma and UPS patients, not really to our dedifferentiated liposarcoma cohorts. And then one thing we've been thinking about with our colleagues across the country is developing a more easily performed with more quick turnaround time IC-based biomarker to select patients with sarcoma immune class E-like tumors. So originally, sarcoma immune class E was defined using a nanostring custom probe set panel. Although CLIA laboratories in the US, some of them have nanostring and they have tests that can be performed in the clinical setting. The turnaround time is not a couple days, it's longer than that. And this is maybe not a test that all, clinical laboratories and pathology in smaller hospitals can perform. So one thing we would like to do and that we're working on with collaborators at Moffitt is to develop a surrogate for SIC that replaces the need to extract RNA from samples and then evaluate and generate this RNA-based signature, just doing it using tumor markers that we can analyze from paraffin blocks. And then the last remaining question is, what's the optimal length of this treatment? So of course, this is quite expensive treatment now. Many of our patients at MD Anderson are coming from quite a long distance. So in fact, they're actually getting their chemotherapy closer to home in their home state or in their home regions of the country. In the melanoma setting, there's been some studies that show that really the most effective treatment for immunotherapy is given in the pre-op setting, and you can get very good response rates even with 1 or 2 doses in the pre-op setting. And it's not clear that all this adjuvant treatment is really necessary. So I'm going to end with a recent case that of a patient I took care of. He, was working out in the gym. He thought he was getting like asymmetric hypertrophy of one pec muscle over the other until this tumor started to grow pretty rapidly. So he came to us. At the time that he came to us, he had about a 10 centimeter tumor in his pec, not very well imaged on CT scan. So this was his outside imaging. We performed a core needle biopsy. This actually showed a high-grade myxofibrosarcoma, and we offered him preoperative radiation with concurrent pembrolizumab. He had a nice kind of stabilization of his tumor. It's kind of stopped growing. By the time he had surgery, we resected, and oftentimes with these myxofibrosarcomas, if you recall, they often have these tails, both radiographically and also microscopically. So it can be difficult to achieve a negative margin. So for these particular tumors, I tend to do a staged reconstruction. So I'll do a resection. I'll await the final margin assessment by the pathologist, and I'll schedule a second coordinated operating room date for the reconstruction. That way, if the margins are positive, I can go and re-resect more at the positive aspect before we do a flap reconstruction. So this is in the case where reconstruction requires a rotational flap or a free flap, something more complicated than a simple closure. So he had this resection with a delayed closure, actually had pretty good treatment effect. I would say that sometimes we see treatment effects that are like in the 90-something% or even like no viable tumor left. So I would say his is kind of a moderate response, and he's about a year out from the surgery. So we'll see how durable his treatment response is. So the key takeaways, I would say, so of course, as this group knows, the multidisciplinary management of many patients with these advanced cancers is challenging, but certainly for this rare group of tumors, it's challenging in our practice setting in the US. There's a lot of variability even within institutions at a given hospital and across institutions in the country and also internationally. So one of the things we recognize is that although immunotherapy is often available and covered by our insurance payers, that may not be the case in Canada or Europe or other institutions and other countries. Collaboration is really integral. So we have clinic here all together. Like, so our offices are based in our departments, but we go to the clinics, and our clinics are disease site specific. So we go to the sarcoma center, and I share patients with the medical oncologists and radiation doctors that have clinic on the same day that are in the same physical space. And our patients will kind of see all of us on the days that they come to Houston for their follow-ups or for their new patient appointments. And we pretty much, I mean, we don't tell the patients what chemotherapies are going to get or that they're going to get radiation, but we pretty much can predict what each other is going to offer at this point. We work so closely together and share so many of our patients. There really is an evolving role for radiation in combination with immune checkpoint blockade for a select appropriate subset of patients. With sarcoma, there's of course indications for immunotherapy in the metastatic or unresectable setting. There's increasing use of combination immunotherapy with radiation for these extremity UPS and MFS cases. And then now there are a lot of trials trying to combine cytotoxic chemotherapy, so adriamycin with pembrolizumab or anti-PD-1 therapy with radiation. So we have one of these studies that recently just opened at our institution for resectable tumors, and I know there's others in the country as well. So with that, we have a few minutes left, 15 minutes left, which I think is what we were targeting for questions. Wanted to acknowledge all the people in our institution, you know, my former mentors and collaborators that I work with now on the research side of things, and then different funding funders and sources of funding, including our patients that are grateful patients, Mr. Scott and Mr. Chirath. So thank you, and happy to take any questions. Also happy to chat offline anytime. Oh,
Great.
and
Thank you.
this is the info for Strauss too. I don't know if it's open in Israel at all, but this is anybody interested in this randomized chemotherapy versus surgery alone trial for retroperitoneal sarcoma. This is open in Europe, Canada, US for sure, and Australia.
Great. Thank you, Emily. So I had a couple of questions, and then I thought, obviously, I wanted to hear what everybody in Israel thinks, and then to see whether we can draw any comparisons and contrasts between the management of sarcoma in the US and in Israel. I was just interested in the sort of referral centers. So 5% of patients in the US are treated at these centers. So how many centers are there? And then do you see any differences in either the sort of disease that you're treating versus the sarcoma that might be treated in a more of a community setting? And then, you know, how are the outcomes? And if there's any difference, is it because you're seeing a different disease, a more aggressive disease maybe, or a more advanced stage? Or let's say you have a favorable outcome, it's because of what you're doing for the same sort of disease versus what might be done in the community?
So that's good question. And not perfect answers to those questions. So what's a sarcoma center? I think in like France and Italy, where there is established sarcoma center network with definitions of what makes a sarcoma center, it's a little bit easier to answer that question. I often will tell my patients, it's not that we're like technically better surgeons here. Like we're not. There's some phenomenal surgeons in the community and in, you know, other cities and non-cancer centers in the US. It's really the pathology, the radiology, like the expert, um, uh, the expert team, right? So about 20, I would say 20-25% of our pathology. So most of our patients have a biopsy that was done outside. And an outside pathologist said, oh, this is sarcoma. And then we will always have that pathology sent to us, and our pathologist will review the slides. They'll request unsaved slides to do further analyses if they feel like the diagnosis needs a little bit more workup than what's been already done. And I would say about a fifth of the cases, the diagnosis for sarcoma will get either refined or altogether changed. And that can affect the management. So I think that's number one. Number two, the radiologists, you know, if you fell out of bed and you have a fracture, I would not, you know, our radiologists are not really looking at images with that mindset, but they are very good at looking at different types of sarcoma. And so we have a group that's very interested in radiomics, looking at MRI features to try to augment diagnosis and also look at treatment responses and prognosis. So I think radiology is also very important. And then the discussion between our groups, like when, you know, knowing when a patient might benefit from a discussion with radiation oncology or medical oncology before jumping to surgery. So I think it's really the multidisciplinary discussion that's a key component to what makes a expert sarcoma center. The challenge in the US is one of my colleagues loves to like take the map of Texas and put it on top of Europe, because the state of Texas is like the size of Europe, right? So I have patients that come from El Paso, which is an 8-hour drive, or it's something really long. So they are actually closer to California than they are to Houston. We also have patients that are, you know, a 6 to 8 hour drive in the valley, which borders Mexico, but the healthcare down there is really not very good. And the patients there are socioeconomically, you know, in tougher situations oftentimes. So for them to even take time off to drive up to Houston to do their visits, to stay here for surgery, it's a big financial stressor for them. You know, my friend also used to practice in the valley, and a lot of patients were getting toilet mastectomies. You know, they would pay $200 to get a toilet mastectomy. And so that's one challenge in this country is we don't have we have a lot of patients that are underinsured or uninsured. We have a lot of variability in, you know, healthcare coverage. And then we have very large travel distances and very heterogeneous quality of care across the country. And some patients also just don't want to travel. They want to be treated locally. Like they just don't want to go from Minnesota to Houston or Minnesota to Boston. The other challenge when we look at our national databases is what makes a high volume sarcoma center. It's really hard to parse the data out. Like we did a study when I was a fellow, where we're trying to like look at outcomes of patients who were treated at a high volume versus a low volume center. And in the NCDB, which is a national database that many cancer centers, NCI designated cancer centers participate in, only a handful of centers do more than 10 retroperitoneal sarcoma cases a year. That's the whole center. So even finding a group of, you can't even find a group of like 40 hospitals that do 10 RP sarcoma cases a year, you know, much less an individual. All of our surgeons here will do that volume in a year ourselves, right? And so, you know, when you're looking at outcomes, you can't really compare 5 hospitals against hundreds of hospitals. So all the data sets and publications that are looked at volume outcome have always kind of picked this 10 cases a year cutoff, but that's because that's what's available to compare. And so in publications where they looked at high volume centers that do 10 or more cases a year, the patients do have better outcomes compared to centers that do less than 10 cases a year. In France, they have a sarcoma network where they have sarcoma centers that are expert, that do high volume, and they have expert sarcoma faculty. Then there are centers that are in network but are lower volume, but they have access to the same tumor boards, they get access to the same pathology review. And then they have just non-network centers. So when they look at those three groups, the middle group that have access to the sarcoma multidisciplinary discussion at the larger centers, those patients do just the same as the higher volume centers. But the ones that are out of network that don't have access to that multi-D discussion and expertise, their patients do worse. And then in the US, you know, the other thing that I think not being treated at a referral center leads to is just unnecessary procedures. So many of our patients, when we meet them as new patients, they've already had sarcoma treated somewhere else at some point in their life. It could have been at the original, you know, liposarcoma diagnosis. Somebody took out the tumor and then they come to us maybe 10 years later or 5 years later with a recurrence. So we're often dealing with recurrent disease, or also common is they had a lipoma, it was taken out, oops, it's a high-grade liposarcoma, and they get referred to us. So I've had a case where a patient had a fatty tumor in the back, it was taken out, excisional biopsy. We met him in clinic, you know, and the reason he came was because he had positive resection margins, but on an exam, he had a massive tumor in his pelvis. So that wasn't met. And even just a simple abdominal exam would have, you know, led to the diagnosis. So I would say about a third of our patients that we meet as new patients here are untreated in the surgery clinic in sarcoma. But the majority of them are recurrent patients with recurrences. Their initial treatment was elsewhere, or patients with a new diagnosis. They've already had an excisional biopsy somewhere else. And then they were discovered to have sarcoma, and now we're trying to provide definitive management. Does that answer your questions?
I think so, yes. I'd like to see what the comparison is with what goes on in Israel for a rare disease in a small country. Ellie, what comments do you have about sarcoma treatment in Israel in general in the north?
Yeah, thank you very much for your lecture. It was very clear and very deep overview of the subject. Our system little bit is different because in my country, as a general surgeons, we are treating only retroperitoneal sarcomas, not extremity sarcomas. So all question I will ask you related to retroperitoneal sarcomas. By the way, we did a huge case 2 days ago. We had patient with 38 centimeter retroperitoneal sarcomas. So we did radical surgery with nephrectomy and splenectomy, and actually it was the left side quadrantectomy, okay, because the tumor was occupied all those organs. I want to understand your policy because in my country, all institutions, they have different policy. Someone likes to take biopsy, someone likes to give upfront chemoradiation therapy and then surgery. You know, those cowboy surgeons, they can resect everything, so they are going through the surgery directly. Okay. I will ask you short questions, and if you can give us very short answers, okay? So I'll give you example of very simple patients. Okay, someone 60 years old patients is coming with abdominal discomfort. You are doing CT examination, and there is retroperitoneal tumor, most probably liposarcoma. Biopsy can, yes or not?
I would, in a so if it's a tumor with fatty component and high-grade component, it's most likely a liposarcoma.
Okay.
All right. And if it's a patient that I'm not likely to recommend chemotherapy or radiation to, then I don't need a biopsy.
Okay, so you are going to the surgery. Okay.
Yes, but if it's a rapidly growing tumor, the patient has sometimes these D. diff lipos will cause fevers, weight loss, malaise, like
Mhm.
inflammatory symptoms. Those tend to be more aggressive, and we will
Okay.
consider chemotherapy. So if you're going to do
So
chemotherapy, then you do need a biopsy, or some of our medical oncologists will do a PET scan and would be willing to treat on the basis of FDG avidity in a radiographically suspected liposarcoma.
okay, so next question, what is your criteria of resectability? When you are looking on the CT scan examination, actually, I will ask what is the contraindication of resectability in your hands?
What is what?
Contraindication for resectability.
Contraindication.
Yeah.
You know, I think this would probably be like a good thing to like just do a case review hour, right? With just looking at different types of cases and how they were managed. You know, there was an international tumor board. The TARPSA group has an international tumor board, and there was one case where Sylvie Bonvolo was talking about taking out the remaining kidney in a patient with recurrent liposarcoma and putting them on dialysis. And everyone else was like, no, we would debulk. So one person's definition of what's resectable is different than someone else. I had a patient where they had poor kidney, they had two kidneys, but their kidney function was not great. So they already had CKD. To remove their leiomyosarcoma would require resecting their IVC in one kidney and then reimplanting the other kidney, you know, which puts that second kidney at risk. And they had not a small likelihood of post-op needing temporary dialysis at least, if not potentially permanent. So that technically is resectable, but is it really resectable for that patient? Right? Can that patient tolerate the surgery?
If you are getting negative margins after surgery, what is your policy?
So for liposarcoma, our pathologists do not document anything about microscopic margins. So our pathology reports on liposarcoma, there's nothing about pathologic microscopic margins. It's assumed they're all positive. For leiomyosarcoma, we of course do want to achieve negative microscopic margins at the vein margin, but sometimes these tumors, like I showed you in that picture, they're abutting the spine, they're abutting the nerve roots, and I will often give radiation in that situation, but not everybody would. You know, recognizing that that patient has a higher metastatic risk than a local recurrence risk.
What is your policy of surveillance? I mean, how you are following your patients? I mean, how often you are doing an evaluation?
Yeah. So again, an area of active discussion, right? Because it's quite costly to the national healthcare system and to the patients, especially the ones that travel a distance to come to see us. I would say in general in the US for high-grade disease, high risk of recurrence, most of us are doing surveillance every 3 to 4 months. For lower risk disease or people that have been out without disease recurrence for more than 2 years, we often will go out to every 6 months. And then past 5 years, we'll usually go to once a year. And then as they get closer to like 10 years, we'll start doing every other year. But I've had one patient, for example, that I met 17 years after their myxoliposarcoma with a metastasis to their
We
liver.
had a couple of patients. I mean,
Yeah. So it's like, when can you stop following? I will say with older patients that are not very healthy, or as patients get older, one discussion I do have with them and their family members is at some point when they become, when their medical situation becomes to the point where if you find a recurrence, you wouldn't treat it, that's kind of the time to stop surveying, right? If it's not going to change how you manage them. So, you know, I do have that discussion. Like there's some patients with recurrent liposarcoma and we're following it for a while. Then they start to get in their like late 70s and it's like, okay, we're going to do one last surgery or we're never going to operate again, right? We got to decide at some point when are we going to stop following and when is surgery no longer going to be in the picture?
And my last question, actually, most important question I would like to ask you, what is your policy for recurrent disease? You know, radical surgery,
Yeah.
other modalities, what is becoming in Israel very popular, radiosurgery, SBRT, okay, for recurrent disease, high dose radiation of small recurrent tumors.
Yeah.
So can you
Again,
comment?
very, very, very case specific. And
Mhm.
I do think, in a group of surgeons, probably like having somebody just do a case discussion, like just time where everybody just talks about cases is probably going to be interesting to you guys. For recurrent disease, again, it depends on how much time has elapsed from the primary tumor to the recurrence. So if it's a liposarcoma and it's been a long time, 5 years, 10 years, we'll often just do upfront surgery again.
Upfront surgery, yeah.
If it's only well-differentiated liposarcoma, no dedifferentiated, we are starting to do case by case selectively consideration of pre-op radiation. So if it's a liposarcoma that's low grade, and it recurs as only low grade tumor, didn't have radiation before, we might consider giving radiation followed by surgery to try to decrease the likelihood of another recurrence, right? But only for low grade liposarcoma. If there's any high grade, we don't tend to give radiation. If it's a short disease-free interval, like that guy with the rhabdomyosarcoma in his back, somebody took out a huge area of his back, and then he developed nodal mets clinically, became positive. That's one where we hesitate about just jumping in and doing another surgery because it's just going to keep popping up, right? So that's a case where sometimes we didn't do chemotherapy because that patient, number one, what was offered at another institution was almost a year worth of chemotherapy before surgery. Number two, the chemotherapy doesn't really work in that disease, but we did do radiation first for a couple of reasons. One, to give it a little time, because if he keeps popping up with other sites of disease, we're not going to operate during, if that proves itself to be the pattern during radiation, which is often about 3 months. If you do the full conventional fractionation, that helps you decide not to operate because the surgery is not going to help him. And number two, there's a potential it might help get you a little bit better local disease control. So I think histology, disease-free interval, what kind of surgery would be required, all factors into how we manage a recurrence.
And one more question. One of the biggest problem of these patients is recurrent surgery and the quality of the life after recurrent surgery. Do you have any specific program to improve quality of life of those patients?
So quality of life after surgery, not specifically. I would say we are using prehabilitation. We have a prehabilitation program here, and that's helped a lot in getting patients in better shape for surgery. And that works here because we do so much preoperative treatment. So they're doing 4 months of preoperative chemotherapy, another 3 months of radiation followed by the radiation treatment break. So people can make a lot of progress in terms of their nutrition and function, exercise tolerance during that time with the prehabilitation program. Post-op, it's much more difficult because, our patients don't, most of them do not live here in Texas. They are out of state or just from far distances. So I think quality of life is definitely something. We have a recent faculty recruit that's interested in that. I think that would be nice to look into, but it's not something we actively have a program in.
Thank you so much. Thank you.
Of course.
Right. Thank you. Thank you, Eddie. Any other questions before we wrap up? Okay. Well, thank you very, very much, Emily. That was fascinating and a lot of food for thought. And it's interesting to see the difference between a large country and a small country in dealing with a rare condition.
Yeah.
So thank you again. Thank you, everybody,
you.
for attending. And just to remind everybody that in 2 weeks' time, which is on the 18th of November, again at the same time, we've got a round table on robotic surgery. We have Ellie, I hope, and some of the other guys presenting a couple of robotic cases of our own. Right, Ellie?
Yeah.
And we'll also have a couple of other participants in the roundtable. Steve Wexner, right, very eminent colorectal surgeon, previously of the Cleveland Clinic. Now he's moved to Washington, to Georgetown, and Manish Chand, who's a robotic surgeon from Imperial College in London. So that should be very interesting. And reminders will be going out again soon. For that will be 2 weeks from today. So thank you everybody very much for attending. We're going to upload the recording onto a YouTube channel so that you can watch it. And Emily, thank you very much
Thank you
for
very much.
a
Thank you for the
wonderful,
invitation.
Thank you.
wonderful session.
Nice
Thank
to
you,
meet you
everybody.
all.
Have a great
Thank
rest
you.
of the day.
Bye-bye.
Emily, thank you. Bye-bye now.